Welcome. My name is Amy Smith. I'm the Bariatric Program Manager here at Northeast Georgia Medical Center. And today's talk is about how metabolic and bariatric surgery can impact common chronic health conditions related to obesity. So just want to start out with a couple of items about our program. We have multiple treatment options here available to our patients for obesity. The first of them is medical nutrition therapy. That's meeting with a registered dietitian to kind of go over what your health habits are on a daily basis. A lot of times it can take just a few little tweaks in your diet to see some weight loss. We do have medical weight loss here in our program with obesity medicine specialists. We do have a non-surgical procedure called the intragastric balloon. And then, of course, we've got metabolic and bariatric surgery, which is what today's talk is really going to focus on. So without further ado, I would like to introduce Dr. Miguel Del Mazo. He is one of our metabolic and bariatric surgeons, and pleased to have him here today for today's talk. So I'm going to stop sharing my screen, and I'm going to turn it on over to Dr. Del Mazo.
Hey, thank you so much, Amy. Full disclosure, I'm not a Zoom expert, so I want to apologize if I click a few buttons here and there. I apologize. I really do appreciate everybody coming out and being part of this presentation. It's something I really love, I feel passionate about what we do. Obviously, we're trying to change lives, not just change health conditions. But if it's okay with y'all, I'll go ahead and start the presentation. Like Amy said, I am Miguel Del Mazo, one of the bariatric surgeons here at NGMC. I'm just going to talk to you about what I do and some of the pathophysiology of how metabolic and bariatric surgery can impact the conditions that we see in the hospital every single day. Disclosures, I have no relationship to industry or any sponsorships. Every year, the CDC releases the 10 most common causes of death in the United States that they view are preventable in some way. And that begins with things like heart disease, cancers, lung problems, stroke, accidental death, Alzheimer's disease, diabetes, pneumonia, kidney disease, and suicide. And these numbers haven't really changed dramatically over the last 5-6 years. They've been holding pretty steady, unfortunately. We'd like to see some decreases, obviously. There's one big outlier that's obviously in the news, and I think you may have heard of this one. COVID-19 is responsible for over 300,000 deaths last year. That number is thankfully trending down, and hopefully we're coming to the other side of this pandemic. But that's the only number that's kind of unusual in its trend. Heart disease is topping around 650,000, cancer in the 600,000s. These are considered preventable deaths because there's things we can do as providers, as individuals, to hopefully mitigate that risk. Separate from that, the CDC releases the top 10 causes of death. The NIH releases a list of things, diseases they feel are associated with obesity itself. And if you go down the list, and I'm going to try not to just read my slides. I've watched enough of those presentations when I was in medical school to know that my favorite type. As an aside, by the way, I would love to have questions at the end. Any questions that pop up, please write them down, send them to Amy. That to me is the most fun part of being a presenter. But the NIH releases their diseases associated with obesity list. If you look at them, there's a lot of overlap there. And a lot of the most commonly, most mortal diseases in the country are also the ones that are associated with obesity. And that wouldn't necessarily be a problem, except for the fact that obesity is incredibly common in our nation. The CDC used to report the data a little bit differently. You may have seen the progression from the 90s to the early 2000s of the country just getting redder and redder and redder and redder and redder as the rate of obesity increased. They've changed a little bit how they report the data. It's now self-reported by state. And what you see is, again, the population is getting redder and redder as the country gets more and more and more obese. Georgia is one of the few southern states that's actually only orange, but still not as low as we'd like it to be. If you look out in the Pacific Northwest, there's always some areas they're a little bit lower. But every state that reports has at least a 20% obesity rate in its population. And that's pretty significant when you start factoring in the idea that things that are associated with obesity being very common, now all of a sudden starts to give you the idea that this is a very common problem that leads to mortality, leads to death. And so I highlighted on this slide the 6 diseases that are in red have a clear-cut association with obesity, morbid obesity, even being overweight. The 3 in orange have a pretty strong association in the data, but aren't necessarily as crystal clear. Unintentional injuries, interesting enough, actually has some association with obesity in the literature, but I didn't think it was fair to put that one down. It's not as clear cut. I know even as a surgeon, I can be a little clumsy at times, and so I don't want to put any kind of bias there. And then I feel like it's 2021. I'm morally obligated to have a COVID slide. There is an association with obesity and death from COVID. That's pretty clear cut in literature. This data got out very quickly in last year. It's a J-shaped curve, which means if you look at the lower weight population, the mortality for COVID is actually relatively low, and then it gets very spiky very quickly as the BMI goes up. And I know BMI is getting more and more to be a well-known term, but for those of you who don't know, it's a body mass index. It's a way of measuring your height and your weight, doing a little bit of math and kicking out one number. And the reason we use the BMI as opposed to pounds or kilograms specifically is because it's not fair to compare a 4'11" patient and a 6'11" patient. They should weigh different numbers. But this is a way of kind of standardizing across heights. But yes, as BMIs cross past 25, which gets into overweight territory, mortality goes up. As we go into past 30, which is obesity, by definition, we get more mortality, and across 35, it definitely continues that sharp upward trend. So that's COVID. The big 5, as we kind of know them in the bariatric world, are 5 disease processes that are clearly affected by obesity, and you'll come to see at the end of the presentation that they're also improved by treating obesity in a surgical way. Those big 5 include the heart disease, cancers, chronic respiratory problems, pulmonary problems, stroke, and diabetes. And I'm talking to an audience that is in the hospital day in, day out. These are the patients that you come to serve. These are the patients that you treat. This is how we treat them as surgeons. Heart disease, cancers, chronic respiratory problems, stroke, and diabetes are incredibly common in our population. They're common across the United States. And there are things that obesity does to exacerbate them, to cause them, to make them worse. At its core, obesity was originally taught, at least when I was in high school and my gym teacher was teaching us obesity, a very benign, it has its problems in terms of joint pains and back pains, but it was very metabolically boring. You take in too many calories, you store those calories, they get stored as fat. And as you store more calories, you have more fat cells. And we've come to find out over the past 20 years, where there's been intensive interest on the researchers, all the PhDs, and the MDs that are doing more kind of bench level research, what it is that obesity is doing. It's not just storing energy. The fat cells in one's body are incredibly metabolically active. They're doing a lot of things kind of behind the scenes. White adipose tissue is the visceral fat, the fat that kind of surrounds kidneys or surrounds internal organs. And it is an endocrine organ, the same way that a thyroid or pancreas is an endocrine organ. It secretes hormones that go either within the cell itself or go outside the cell and change how the body works. And the bioactive molecules, I'm going to mispronounce this because I always mispronounce it, but adipokines always are the main bioactive mediator of those communications. They regulate glucose levels. They regulate how your body interacts with cholesterol and other lipids. It affects your blood pressure state. It turns on the inflammation cycle, and also how you deal with oxidative stress. So they're incredibly important, incredibly universal. They affect almost every cell of the body. The adipocytes, or the fat cells, also release free fatty acids, which are another combination of fuel source and a biomarker that can stimulate macrophages, which are a type of immune cell. And I put the stuff down there for the total receptor factor 4, and nuclear factor kappa beta, tumor necrosis factor alpha. There will not be a quiz at the end, but just to let you know that we are starting to understand these things, not just at the very superficial level. We're actually starting to get a better understanding more at the molecular level between cells. This data is getting out there. And again, very important in the literature in terms of how much excitement there is about trying to get an understanding at a more root level. But the end result of what those white adipose tissues are doing is leading to an upregulation of procoagulant factors. It turns on the body's ability, sorry, oops, now away from the screen, turns on the ability for the body to clot, which when you think about how cardiovascular disease and stroke commonly work, when you have an artery and a clot blocks that artery, blood can't get through, oxygen can't get through, nutrition can't get through, but acutely the oxygen not getting through can cause tissue death on the other side, downstream from the clot. If you turn that system so it's hyperactive, you're getting more clots, you're having more ability to block off the arteries in the heart, block off the arteries in the brain, and that leads to cardiovascular disease, that leads to stroke in a very direct way. So fat cells are active and they turn on the mechanisms that lead to cardiovascular disease and strokes, significantly increasing the risk of those diseases. We talked about free fatty acids and how the adipocytes release that. And those have an effect downstream as well. So the adipokines turn on the procoagulation cascade. FFAs can turn on, can affect the pancreas rather. So in the short term, they do a good job of powering the pancreas. If you didn't have a good fuel source for the pancreas, FFAs can be substituted in their place. But over the long term, that seems to downregulate the pancreas's effect and the ability to produce the hormones that it makes. Obesity increases FFA, and this may be part of the reason why the pancreas gets affected and downregulating its insulin in the long term. FFA also works on the cells the pancreas is trying to target. So as FFA goes up, insulin resistance in the peripheral cells go up. So you can imagine that a cell that's supposed to hear a signal from the pancreas, that signal was muted by its exposure over time to FFA. So in the periphery, you see less insulin or insulin working to a lesser degree, which means the pancreas has to ramp up its production to get the same effect. And there's a downside to having too much insulin in your system. There's a very significant downside. And we'll kind of get back to that in a second, because insulin is a growth factor. Insulin turns on cell development, cell growth and division. And this is actually part of how insulin, how obesity promotes and encourages cancer cells to grow. Once again, we see inflammation rearing its head again. Inflammation is a big boogeyman in the medical literature. Inflammation turns on a lot of cascades that are, in general, positive in the right amount, the right context, but just generally being pro-inflammatory is not a good thing. Insulin also, as a growth factor, encourages that cell growth. Cell growth implies cell division. This is kind of getting back to some basics with cancer. Every time a cell divides, it has to copy the DNA inside it and give a copy to the new cell and keep a copy for the old cell. And that division isn't always perfect. You can imagine, someone transcribing letter by letter the genetic code from one cell to the next cell. If that doesn't happen perfectly, errors can be introduced. And if those errors aren't caught and fixed, those errors can be the error that leads to a cancer. So everything that encourages more cell division, more active cell division, more errors to occur, increases the risk that one cell kind of goes rogue, which is essentially what cancer is. And when that cell goes rogue, that leads to a cancer. So insulin being upregulated by the exposure to free fatty acids in the state of high obesity increases cancer in a fair number of cancer types. And then those visceral fat cells, those white adipose tissue cells, also convert testosterones into estrogens. So they're not just sitting there producing stuff, they also intake things, put a conversion, and then export so they import testosterone, convert it, and export estrogens. And in certain cell lines, breast, ovary, for example, estrogen itself is both pro-inflammatory and encourages cell division. So you have a kind of a triple whammy of how obesity is pushing cells towards cancer. This is from cancer.gov. There are a number of cell lines. You can basically think of any soft tissue. There's a good chance there's a type of cancer that is encouraged by obesity. It seems to spare muscles, seems to spare bone, but most any other soft organ you might have has a higher risk of cancer associated with it because of obesity. Going back to the big five again, the obesity is related to respiratory disease, pulmonary diseases. People's lungs are designed for a certain size. There's an amount of surface area in there. The resistance that comes between breathing the air in, going down the windpipe, into the lungs, is designed for a certain amount of resistors. And you can imagine that as we get bigger, there's physical impediments against the taking a breath in. There's also that pro-inflammation going on again. There's also the risk of pulmonary embolism, which is a blood clot getting caught in the vasculature of the lung, which goes up in that pro-thrombotic, that pro-coagulation state of obesity. Aspiration pneumonia goes up. This is actually more of a physics thing again. The weight pushing on someone's belly can push acid from the stomach up the windpipe and have it fall down into the esophagus, rather, into the windpipe. Sorry about that. So there's a lot of things going on causing the lungs of someone to be relatively at risk because of the obesity. So it's unlike the diabetes itself or the heart. This is more about physics and biochemistry. Now, all the bariatric surgeons at Northeast Georgia, we belong to the American Society of Metabolic and Bariatric Surgery. We're all actually fellows in that college. And this is the college that kind of watches out for bariatric surgery. We do research. We provide guidelines to the members. It is like the American College of Surgeons, but for bariatric surgeons. Now, it used to be the American Society of Bariatric Surgery, and they added the word metabolic in there. I just want to kind of highlight why they did that, why we did that. You may have heard the surgeries that I do called weight loss surgeries. And I think weight loss surgery is a perfectly fine word to use, or a series of words to use, but it doesn't get at the heart of what we're trying to do. We're not just trying to make skinnier people or skinnier patients. We want to affect people's metabolism. We want to affect how their body regulates things between the cells, how disease processes are affected at the metabolic level. And so they added that word a little while ago to kind of highlight that it's not just bariatrics, it's not just weight surgery. It really is disease process surgery. And the word metabolic kind of sums that up. Going back to my high school coach, the idea of calories in, calories out as a model for weight loss is insufficient. And these surgeries kind of provided the most clear evidence that it's not just a calories in, calories out model. The surgeries that we do here are all laparoscopic or robotically performed. Of the 4 surgeries on your screen right now, only one is not currently being offered. As far as I know, the band, I don't think any of the surgeons do the band anymore, but bypass, sleeve, and switch are all options. All of them involve doing something to the stomach's anatomy. The bypass and the switch, you also bring it apart where you move the bowels around a little bit, kind of do a little rerouting. But the end result of all 4 of these surgeries is we're trying to limit food intake. And actually, I'm sorry, not the band, but the bypass, the sleeve, and the switch. All 3 of these surgeries, we're trying to impact how the body responds to the stimulus of food, where that food that we take in, where does it hit in the stomach? Where does it land? Where does it arrive? What cells does it turn on? What cells does it deregulate because it's not seeing the food? Because when those cells are impacted by touching food, they turn on a whole cascade of things that affect the metabolism, not just the weight. And this is the Foregut hypothesis of weight regulation. And go back to my high school coach, it's not the calories coming in. It's pure and simple. It's not just what you take in. It's what that food does. What kind of food? Is it made of fat? Is it made of protein? Is it made of carbs? When that food comes in, it stimulates parts of the gut and turns certain cells on, turns certain cells off. And it does that through a series of hormones. And there are a lot of them. I put down a fair number of them. There's actually there's over 100 gut hormones that we know regulate the body's homeostasis, the body's ability to maintain its specific weight. You can imagine this idea of homeostasis, this idea of the body is trying to preserve a specific weight as a thermostat in your house. So you go to the dial and you turn the dial, or if you got a more modern one, you kind of hit the buttons and you set what temperature you want your house to be at. And it could be 78, it could be 68, but you set the temperature, whatever you want it to be. And that box does not change the temperature of your house. It communicates with an air conditioning unit on the outside. That machine then does what it does to affect the temperature of the house, bring it down, bring it up, whatever it needs to do. But the box itself has a setting. And you've probably seen this if you've lost some weight and gained back a little bit. That setting is trying to be preserved. You may go up a little bit, Thanksgiving, Christmas, but you come back down again. The body's trying to maintain where it's supposed to be. And the way that it does that, you can imagine, this is just kind of my own little slide, and it's not beautiful and elegant, but I apologize. But you can imagine there are 3 different ways your body spends calories. The yellow is fixed. You have to give calories to your heart. You have to give calories to your brain. Your kidneys need some calories. That you can't affect. What it needs, and there's no you making a decision or your body making a decision to not provide it that day. There are the calories that you burn because you choose to, and those are the ones in red. So if you go from having a kind of a standard American life, we watch a little TV, we get to work, it's saying, you know what, I'm going to run a 5K next year. You start that process of training for it. You're going to increase that red bar. It's going to go up a fair amount. The tricky part is the body recognizes when you've increased the amount of calories you're choosing to spend. You're, from your own free will, choosing to make a difference. It's going to go down on the regulated. And the regulated is those calories that it chooses to burn or to store. We all waste calories every single day. But based on a number of factors, both environmental, hormonal, genetic, how we choose to store those calories or burn those calories and let them kind of go to waste, essentially, is very tightly regulated by some of those hormones I was talking about in the previous slide. When you go up on your elective calories, the calories you choose to burn, your body will oftentimes do a similar decrease in the amount that it burns in that regulated state. And so your net change isn't, it doesn't change the needle, and move the needle on the weight. It doesn't change the thermostat setting. To really change that thermostat setting requires an impact metabolically. And that's kind of where we see bariatric surgery come in. Bariatric surgery is not simply rerouting something or minimizing the size of the stomach to decrease the calories in. We want to change those signals that are going on in that blue zone down there. How much is the body allowing to go to waste? Evolutionarily, you can imagine this is a very useful thing for your body to be able to do. If there was a bad harvest, if there was a harsh winter, if there's something that was external to the person, that we could down-regulate how much calories we're wasting, we're choosing to store more, it's very, very functional, useful for surviving that winter, surviving those stressful times. Obviously, we live in 2021, and we have stressful times of our own, but very rarely is food insecurity one of those stressful times. We typically have good access to nutrition. And so this very useful evolutionary benefit is decreased to a degree in 2021. What we see when we do a metabolic surgery, we see when we do a gastric bypass, when we do a gastric sleeve, when we do a duodenal switch, that those adipokines that are known to increase weight, that are known to cause these things, they get affected. And in general, it's kind of a zoomed out view, but the ones that are bad for you go down, the ones that are good for you go up. It's not that simple. There's obviously 100+ hormones getting involved there, but kind of a zoomed out level, bad ones go down, good ones go up. And what we see is a decrease in the weight. We see a decrease in the peripheral insulin resistance. We see a decrease in that, a decrease in the thrombotic state. We're also seeing a generalized decrease in inflammation throughout the patient systems. Now, that's a good thing. And as a result, we don't just see short-term weight loss. The goal for every patient is to go into a surgery that they are familiar with, they feel comfortable with, they feel like they can commit to. And then on the other side of that surgery is a surgeon that will commit to them back and support them over the long term, because these surgeries are designed to last a lifetime with proper care from both the patient and the physician. This is kind of a busy slide. I kind of want to look at the top slide primarily. The early changes that happen right after surgery, within the first couple of months, tend to be more the metabolic changes. And as we get to about three months to 6 months, we start seeing the inflammatory benefits kick in as well. And that goes along with what I see in my patients. When my patients, I see very quick improvement in diabetes, very quick improvement in blood pressure. A lot of times you can actually send people home from the hospital off of those medicines. I'm not sure if it should be said, but I often tell patients that our goal is to make your PCP happy and make your pharmacist a little upset with you, because I'd like to get off those medicines. That's kind of one of the main goals we have. So we see that, and as I said, we're doing a lot of research. So the PhDs are doing a great job of really teasing out what it is on a molecular level that where these improvements come from. The lower slide kind of talks about how the rapid change is seen in those first 3 months and does tend to slow down as you get to 6 months. And this is the slide. This is actually a relatively old slide in the literature, but it's one that got me interested in bariatrics in the first place. Growing up, I actually lost 2 cousins to diabetes complications. And when I saw that after a bypass, after a sleeve, it's possible to see a significant improvement in someone's diabetes scores, that's kind of what drove me to wanting to be a bariatric surgeon. Weight loss is wonderful, but this, I think, is just kind of incredible. And you see the top left square talks about how the hemoglobin A1C improves dramatically. And there's a very sharp line down the first 3 months. For the sleeve, from 9.5 down to 6.6, and bypass 9.3 to 6.4. That sharp curve, you compare it to the change in BMI in the bottom right, it's sharper. The improvements in the diabetes are faster than the improvements in the weight. So it's not a one-to-one relationship. It's not just that losing a pound of adipose tissue sees a certain amount of improvement in the hemoglobin A1C. It's really about something metabolically going on that anticipates the weight loss. It precedes the weight loss. It comes before it, and it's actually a little more powerful than just the weight loss itself. And I love the slide on the bottom left. That's part C, just showing the decrease in the number of diabetes medicines that patients take after bariatric surgery. That to me is just super cool. So going through some meta-analysis, how does metabolic surgery affect the big five? What is it doing from a not molecular level, but from a zoomed out morbidity data, mortality data? What is it doing? Well, heart disease in a non-randomized prospective study, but the patients are matched. The heart disease risk, the risk of dying from heart disease for a patient who could have gone through surgery and didn't, compared to someone who did go to surgery, actually reduces the mortality by 56%. Cancer mortality in cancer patients who are post-bariatric surgery compared to matched patients decreases by 60%. The most associated respiratory disease with obesity is obstructive sleep apnea. 75% of patients see improvements in their sleep apnea scores, some of which they can actually come off their CPAP machine entirely. Stroke, also 66% decrease in fatal stroke risk and 34% decrease in overall stroke risk for patients who went through surgery as opposed to those who could have but did not. And then diabetes, this is the one again that kind of drew me to being a bariatric surgeon in the first place. Diabetes associated deaths in post-bariatric patients, post-metabolic surgery patients, goes down by 92%. And that to me is just stunning. You know, I wish this was something that was well known 30, 40 years ago. I wish this was an option for patients that I knew growing up. And unfortunately, it wasn't at the time, or it wasn't very well known at the time. But the era of laparoscopic bariatric metabolic surgery has opened the door to so many people having access to this in a safe way to get these benefits at the lowest risk possible. So I'm going to do a little Zoom magic if I can. I'm going to try to stop sharing this screen and share the other screen. But the big reason why I think how can metabolic and bariatric surgery impact health conditions has very little to do with the scale, has very little to do with, you know, your BMI or numbers. I really don't believe that when we're put on this earth, we're just a series of numbers strung together. We are a person, and people have hopes and dreams. They have fears. They have things that they're trying to accomplish, things that they must accomplish. And so I'd like to show you this little quick video of somebody who's been through bariatric surgery, who has done this, and kind of what her, I think you can see me now, what her journey has been like.
My name is Gwen Garner, and I had gastric bypass surgery April 2nd, 2018. My primary care physician had been discussing my weight with me for a number of years. It was just out of control. I had dieted, I had exercised, nothing was helping. And I went to see him one day and he said, "You have to consider weight loss surgery or you're going to die." Prior to the surgery, I was lethargic, I was depressed, and I was just exhausted. I was short of breath. My knees hurt, my back hurt. I could barely walk down to the end of the driveway to get the mail and back. We didn't do anything fun. When we went in to have the surgery, I was only there overnight, one night, which really surprised me. And I had the surgery one morning. I was up that afternoon. The support groups have been a terrific help. We were going in person until COVID hit. So fortunately, Northeast Georgia has support groups. I've been able to listen in on those support groups. They even have exercise, they have recipes. I can replay them several times during the week if I need to. Rich and I can do so many things that we couldn't do before. We can walk. I mean, I love to take walks. I feed a lot of birds. I'm doing more gardening. I love my flowers and my yard work. We're able to do more of that. We're able to travel more. I have so many people who come to me and they're considering weight loss surgery, and they're just like I was. They are afraid. I was ashamed to admit to anyone that I had weight loss surgery because I saw it as an act of weakness. And so many people think weight loss surgery is the easy route. It is not the easy route. It takes a commitment. It takes counseling. It takes exercise. It takes eating right. And if you're not willing to do all those things, the surgery is not going to be effective. I let them know what a wonderful solution it is to a crippling problem, but that it's not a silver bullet. It takes work. If Dr. Del.
Okay. Try to go back to. I definitely appreciate y'all's patience with me and Zoom. No, that's why we do surgery. We don't do it just to make a number better. We don't do it to improve just a BMI. I want to see people living the life that they feel that is destined for them, that's their life. What their dreams are, they accomplish them. What their fears are, they overcome them. That they can do what they need to do for them, for their family. And I love the fact that as scientists learn more and more and more about how these surgeries work at a functionally metabolic level, that we get to share in that as surgeons. And you probably figured I'm a bit of a geek. I definitely like the science stuff, but seeing people get happy, healthy, doing well, that's the most amazing part. I tried to go quickly through the slides. I know there's a lot getting thrown at you. But I'm really looking forward to the question and answer part. And just because I'm selfish, I wanted to get to that as soon as possible, because any questions at all I can answer for you, I'd be honored to do so. And I think Amy's going to help me curate that, because I'm.
I am. So I have just a couple slides to share with you guys as well. So glad that he was able to talk about that today. Do want to let you know that we have 3 wonderful metabolic and bariatric surgeons here in our program, as well as several obesity medicine specialists that are here to help you. We also have, to Dr. Delmato's point and Gwen's part, where she mentioned about support group, this is really meant to be a lifetime relationship with the program and with the surgeon. And we don't just do surgery and say, best of luck to you. We have a whole program here for our patients. We have a dietitian our patients get to see for free. We have a therapist if somebody needs to spend some time talking through how to make the best, plan for themselves to meet their goals. We do have yoga and weightlifting classes for our patients to introduce you to some light physical activity. We have cooking classes every single month to teach you how to eat healthy. We've got a beautiful clothing closet here, and we do have some support groups both in person and virtually. So about to open up to questions. I've gotten a few here, and so if you've got any other last minute questions, please type them in, but did want to let you know, if you're interested in contacting us after this talk, I've got our phone number here at 219-0446. I've got an email address. If you don't feel comfortable asking questions here, you can submit to our email address. It's bariatric_support@nghs.com. So you can send it there. So I'm going to stop sharing my screen here and open this up to questions for Dr. Delmatho. And I'm getting several here. But first, let's hit the first one. Dr. Delmatho, I had one of our guests here say that she actually had gastric bypass surgery 15 years ago, and she lost 200 pounds at that time. And it says that after she hit the age of 50, things changed for her, and she's actually regained about 50 pounds. But first, I have to say, you have to give credit to yourself, because even maintaining 150 pounds weight loss is a huge accomplishment. But her question is, now that she's gained 50 pounds and she really would like to lose a little bit more, is there a revisional surgery after gastric bypass, or what would you recommend her first steps would be for her?
So there are revisional surgeries that exist. There's a lot of debate in literature about what's the best version, what works the best. I'm kind of old-fashioned. I'm a surgeon who likes to do one surgery, and ideally that be the only surgery necessary. And what I found in my practice is if I can sit down with a patient, talk it over with them, see where they're at in the journey, a lot of times we can actually get back to a lower weight, seeing improvements in diabetes again, or blood pressure, sleep apnea, without having to go to the OR again. The original way I was taught with my fellowship was that these were very mechanistic. You made a smaller pouch, you made a smaller stomach, you did things that were physics-based. And as we kind of saw with the metabolic slides, a lot of what we're doing really has to do with more of the metabolism, and restarting that metabolism going again is important. And so what I see is after 15 years, it is completely normal to have forgotten all the bariatric rules and regulations. It's also entirely normal that science has changed. You may not have heard the modern rules and regs. And so what I like to do with these patients, rather than kind of just go straight to the OR and trim something or reroute something, is sit down, have a long form conversation, figure out where they're at in the journey. Are they getting the 0-calorie liquids? Are they sticking to proteins and veggies? Are they getting some exercise in? Going back to the basics. And on average, in the literature, 4 out of the 5 patients that start that process will see weight loss start at about 1 month. Usually it's a tapering off the gain, and then it starts to be a loss again after about a month, month and a half. So yes, revision surgeries exist, but often aren't necessary. While I'm sitting down talking with a patient, doing this intake and learning where they're at, we also do the appropriate x-ray tests and that sort of thing to see what the anatomy looks like. And if there is something that needs to be changed or can be revised, we are able to do that. But 4 times out of 5, it's not necessary. So patients who are kind of nervous, like, they're going to come and see the doctor and he's going to yell at them, or come see the doctor and they're going to be whisked off to surgery. No, just make the connection, make the introduction to the surgeon, learn where they're at, learn where you're at, and go from there. Don't be afraid to come in. We want to see you.
Great. So here's a great question, Dr. Delmatho. They're asking, what is the recovery like for each one of these procedures?
Great question. So most of the surgery we do are overnight stays in the hospital. We recommend 2 weeks off of school or work. Take a little time, focus on yourself. Okay? Don't go full diva. Don't ring a bell on the couch. We want you up and active, doing real life stuff. But you should feel pretty bright-eyed and bushy-tailed the next morning. Amy knows the statistics a little bit better than I do, but I think our average patient leaves the hospital within 23 hours now, 23 and a half or something.
Yes.
It's pretty amazing.
Yes, absolutely. So one patient is asking, or one person rather is asking, how long would it take someone to lose about 100 pounds after these procedures?
So it's tricky. 100 pounds is hard to say. If you're 7'2", 100 pounds may be very, very quick. If you're 4'11", it may be slower, because what 100 pounds is depends on your BMI. And so the best way I found to kind of describe it is, you can imagine if your weight's here and a BMI of 25 is down here. I'm not sure if it's on my screen, but there's a gap there. There's a space there between your current weight and that upper limit of normal, which is 25. This all is the excess weight. And the excess weight, regardless of your BMI, or regardless of whether you're super tall, super short, somewhere in the middle, whether your weight is 300 pounds, 200 pounds, whatever, that percentage of excess weight lost at about a year is about 2/3. So you can imagine someone who is 200 pounds beyond 25 might lose that 100 pounds within that first year. someone who has less pounds to lose, it may take longer to get to 100 pounds. So I'm not sure if I'm doing a great job explaining it, but the idea is don't go by pounds to lose, go by how much of your excess weight loss you're trying to achieve. And the average person is about 2/3. Now, I will say this, if you're hardcore, if you're learning how to go grocery shopping, if you're learning how to cook, if you're learning not just cook, but cook differently. I'm Southern. Southern food's keeping me in business, learning new styles of cooking. It's not dieting, it's just approaching food differently. If you are hardcore with the exercise, you're going to lose more. If for whatever reason you aren't able to do that, so I've had patients who are missing a leg, patients who have chronic back problems. I'm not going to send that patient to go run a marathon next week. That'd be silly. But if what you're able to do, what you're called to do, if you knock it out of the park, you're going to do better than the average. And that's what we want. We think you're great, but we want you being awesome because you're worth it.
We've got some really good questions, Dr. Delmato, about diabetes. The first question, if we focus on type 2 diabetes first, this question is, does it matter when you have type 2 diabetes, does it matter how long you've had it before you have metabolic and bariatric surgery as far as the remission rates and things like that?
Yes. So the best study about this was probably done about 8-9 years ago. And they took prospectively randomized clinical patients and just kind of split them into 2 groups and kind of matched and saw how the diabetes went down. But they found out when they teased out the data that having type 2 diabetes less than 2 years is very helpful. We're looking at 84% remission rates for diabetes when you have diabetes less than 2 years for the bypass patient population. It's actually higher with the duodenal switch, a little bit lower with the sleeve, like a couple points. When you get to 2 to 5 years and then 5 to 10 years and then beyond 10 years, those numbers do go down. So it seems like the more entrenched the diabetes is, the longer you've had it, the more time it's had to really settle in, the harder it is to reverse the effects. But with that said, even the patients who were greater than 10 years out, the number of medications they were on went down. The ability to achieve a hemoglobin A1C of less than 7, that went up. So even if you can't go into full remission, we don't use the word cure, we use the word remission with your diabetes. If we can get you on less medicines, having to check less often, less finger sticks, a number that you're happy with, the PCP is happy with, we're in the right direction. So that's the goal. It's not just being diabetes free, which would be a dream, and it actually happens for a lot of people. Even if we just get it easier to treat, taken care of better, we're going the right direction.
Great. So the next question says, I have adult onset type 1 diabetes, diagnosed a few years ago. My weight and A1C have yo-yoed. Would bariatric surgery be beneficial for me as well with type 1 diabetes?
I think yes. So I've had, in the last 10 years, I think we had 10 or so patients with type 1 diabetes. It is a more rare form of diabetes, especially as the adult onset. For those, just to catch a little speed, type 2 diabetes, the pancreas makes some insulin, but there's peripheral resistance that it's just not getting the job done. Not the most high level way of explaining it, but that's kind of a zoomed out view. Type 1, there is less insulin to almost the point where no insulin is produced by the pancreas. And so there's similar disease processes, but different. Type 1 patients, in my experience, still need to have some insulin provided to their body from an injection, from an insulin pump, some way of getting insulin to the body because the body's not making any at all. But the obesity still causes peripheral resistance in type 1 diabetics. And so if we can decrease the peripheral resistance, that insulin that's being put in the body is more potent. And so it doesn't have quite the same impact that type 2 diabetics who are freshly diagnosed or who are in the pre-diabetic stage, we see dramatic, hopefully getting rid of all their medicines. I still think the type 1 diabetic patient needs insulin from outside the body, but it goes further. It's more impactful. It gets the job done. And going back to the cancer slide, if we can decrease the amount of insulin that has to circulate in the body, we are improving things besides just the diabetes type 1. So we're trying to decrease the risk of those other associated obesity diseases.
Okay. The next question says, I did the work and I lost the weight. What resources are available to me, or who could champion me for skin removal surgery?
This is one of the biggest challenges in all of bariatric surgery. There are a number of urban legends and myths that if you donate your skin to a burn center, that it'll be covered, or there's like something you can kind of voluntarily do. Unfortunately, one thing I'd say is please call your congressperson and encourage them to encourage insurance companies to actually cover these life-changing surgeries, life-affirming surgeries. Skin is one of the biggest challenges in bariatric surgery. What do you do with the bat wings or the little bit of belly skin? One thing that can be done is to actually surgically remove it with a plastic surgeon. But a lot of insurance companies view this as cosmetic. I do not. If you are having a hard time doing the walking you should be doing for your exercise, if you can't lift the weights because that the skin's in the way, or if you're chronically having irritations or infections in the skin, this is life affecting. If you can't go out or you choose not to go out because you feel embarrassed by the excess skin, that to me, that weighs on your mind and your spirit. We aren't just physical creatures. We have mind, bodies, and spirits. And when one thing is impacting the other, to me, that's part of medicine. Now, some insurance companies get it. They will actually cover surgery for the same reasons I just mentioned, the impact of your ability to exercise, the skin infections, wherever skin's touching skin. They may even cover it for the psychological impacts, but not every insurance company gets it. And so to that end, advocacy, call up your insurance company and say, hey, this is something that's important. Call up your HR department, say, this is something that's important. Call up your Congress critter and say, hey, this is something that's important. Because it's not just enough as a surgeon to get the ball rolling. I want to see, because the most fun part of my job is that I want to see where you're at 1 year, 2 years, 10 years, 20 years down the line. And ideally that's what inhabiting the skin you feel comfortable with. Now, things that you can take personally to improve the skin issue, be young. I recommend it for everyone. It's a great policy. Be as young as you possibly can be. Be male. It's worked out for me. But men tend to have less skin issues. And then be in the gym. Being in the gym, building muscle. Don't just do a lot of reps, low weight. Putting some tone back where the fat cells used to be does help the skin issues. But as far as the insurance companies, lean on them, yell at them nicely, whatever you can do.
Great. So here's the last question for you, Dr. Delmato. What is the most rewarding part about being a metabolic and bariatric surgeon for you?
So the way we set up our clinic and our operative schedule, we are actually in the clinic more than we are in the OR. Dr. Richard and I do 2 days a week of OR days and 3 days a week of clinic days. And that to me is the most fun. I love sitting down, talking with somebody. I think I've been to Disney World through other people 300 times now. I've seen graduations that people thought they couldn't go to. I've gotten to see people's, one of my very first patients when I was an attending, I was about 6 months out from his surgery. I was about a year out from my fellowship. And he just came in and he looked at me. I looked at him and said, hey, how's it going? And he said, great. And he pointed at his shoes. Didn't say anything, just pointed at his shoes. I'm like, okay, well, you have shoes on, great. And he goes, I tied them myself. And that just struck a chord, like, oh my goodness, there's this thing that I take for granted I've done every single day of my life. And I just thought it was the simplest thing. It makes a difference. And the idea that I can be part of that I nudged him in the right direction, because he took the ball and he ran with it. He was doing all the hard stuff. He was doing stuff we asked him to do, the stuff we teach him to do. But that it could be simplified in just one simple gesture that he's pointed at his shoes. That to me is amazing. I love seeing in the patients who are younger female patients who are struggling to conceive. We ask people to try to avoid getting pregnant for 1 year after surgery. But when they come in with their newborn, 2 years later, that's really cool. Most doctors don't get to experience this. I don't think most doctors get to see patients get healthier. We try to slow things down. We try to, I'm gonna add this medicine to decrease this risk. I'm gonna try to tweak this around. I get to see people come in healthier than when I first met them. And that's kind of why you go to medical school in the first place. That's kind of why we're all here at the hospital and doing the stuff we do day in, day out to see people get healthier, but not just in the short term, not just acutely like in the hospital setting, but over the course of their whole life. That to me is a lot of fun. That to me is cool.
Thank you so much, Dr. Delmato, for joining us today. I appreciate this. I know one of the folks that's listening in shared with me earlier that they appreciated the fact that you talked about the word metabolic when it came to this, not just weight loss surgery. And the slide about all the hormones was very impactful. this is very common, but she shared, I've always blamed myself, for carrying the extra weight, and just hearing that there's a reason for that. There's a metabolic reason. She really appreciated you sharing that piece. So thank you for your time this afternoon.
If I could touch on that one thing before I go, please, we would never shame somebody for having breast cancer. We would never shame somebody for having appendicitis. We would never shame them for having a cardiac problem. There's a million diseases in the world, and we would never look down our nose as a provider, as a person in the hospital working, as a friend. We would never shame someone. And there's one exception society allows for. It's obesity. And it's ridiculous. You were made in the image of God. You were made absolutely beautiful. You were crafted with love and care and attention. And you are called to be the most amazing version of you can possibly be. And disease is going to be part of that journey. We all have disease. So don't shame yourself or feel shame or allow someone else to make you feel shame for something that's affected you. That's affected you. That part that's graphed with the 3 different color bars, some people waste no calories. Their bodies are designed to store them. It's designed to hold on to those calories. And that used to be very, very useful. 500 years ago, 1,000 years ago, if you're living in a village, bad winter, bad harvest, those people were able to survive and pass on these genes to their children and their children's children, all the way on down to us. The Paris Hiltons of the world would not survive that. And I'm sure she's a very nice person. Don't tell her I said anything, but I'm sure she's very nice. But your disease process in no way, shape, or form diminishes who you are as a person. It may place limitations on what you feel like you're able to do or what you can do, but you are expertly crafted, lovingly crafted. Don't feel ashamed for something that happens to so many people, so many reasons why. Don't let a number define you. You're incredible. Go out there and be awesome. And if we can help, we're honored to. And if we don't help, you're still awesome.
I love it. That was beautifully said, Dr. Delmato. If any of you out there still have further questions after this talk, you can email those to bariatric_support@nghs.com. You can call us at 770-219-0446. Thank you so much for joining us today. You guys next time. Thank you so much. Bye-bye.